Uh, Good evening, ladies and gentlemen. Uh, at the outset, I'd like to thank members of organizing team for giving me this opportunity. In next 45 minutes, I shall be talking about ultrasound guided blocks for chest wall surgeries. I bring greetings from Asian Institute of Medical Sciences, a 425 bedded multi-specialty and super specialty hospital located in Faridabad in the heart of Delhi NCR. And we do a lot of educational work in the form of DNB as well as RA fellowship program. So these are my set of disclosures for this lecture. I do not have any conflict of interest. You'll find a lot of images which are from Google. References are essentially from PubMed. It's just I'm a RA and a focus enthusiast. In my presentation, you will find a couple of QR codes. If you scan them, they will directly take you to the articles and I'll adhere to the allocated time, that is 45 minutes. This is how I have planned my lecture. I'll be discussing about the anatomy of the chest wall, its innervation. I'll be enumerating various nerve blocks, which as anesthesiologists we utilize in our day-to-day practice. And then we'll study various surgeries where we can actually use them and discuss about prospect guidelines. And in the end, I like to draw a reasonable summary. So, my dear friends, let's understand the anatomy of the intercostal nerves, which are the principal supply to the chest wall. If you actually look at them, they are the ventral rami of thoracic spinal nerves from T1 to T12 and close to mid-axillary line. They give rise to a lateral cutaneous branch, which would first pierce the intercostals, then the serratus anterior, and divide into anterior and the posterior division. Close to the sternal edge, they give rise to anterior cutaneous branches, which further split into medial and lateral branches. But there are certain variations. As we all know that T1 participates in the formation of brachial plexus, so it does not give rise to any lateral cutaneous branch. But if we look at T2, the lateral cutaneous branch has got a special name which is known as intercostal brachial nerve, and it does not divide, and it is responsible for axillar innervation. T3 to T6 are a typical intercostal nerve, thereby meaning they will divide into their lateral cutaneous branches and further into anterior and posterior division. And from T7 till T12, they will innervate the abdomen. So they are known as thoracoabdominal nerve. T12 is a special nerve that is known as the subcostal nerve, where the lateral cutaneous branch does not divide. So throughout their course, the intercostal nerves have been said to give certain branches. These are branches towards the muscles, the collaterals, the communicating, and the cutaneous branches. So, in a nutshell, to say that the innervation of the chest wall is by intercostal nerves and their branches. So, let's understand the innervation of the posterior chest wall, which extends from the thoracic spinous process till the posterior axillary line. It is from the dorsal rami of the thoracic spinal nerve. In addition to that, the posterior division of the lateral cutaneous branches, which originate in the mid-axillary line from the intercostal nerves, are also responsible for innervation of posterior chest wall. Now, the most important for an anesthesiologist is the innervation of the anterolateral chest wall, axilla, and the breast, because majority of the surgeries are going to take place in this area. As I said, the principal component is between T2 to T6, the lateral cutaneous branches on the lateral side. On the medial side, as you can see for yourself, it's the anterior cutaneous branch. In addition to intercostal nerve, brachial plexus elements also contribute to the innervation of the chest wall in form of muscular innervation. For example, medial pectoral nerve and the lateral pectoral nerve, as you can see, supply the pec muscle. The long thoracic nerve supplies the serratus anterior. The thoracodorsal nerve would supply the latissimus dorsi, which forms the posterior axillary fold and is very important when we are raising the latissimus dorsi flap for plastic surgery cases. And the axilla, as I've told you, the intercostal brachial nerve, another branch of the brachial plexus, the medial cord, that is the medial cutaneous nerve of the arm, or the medial brachial cutaneous nerve supplies the axilla. And the relationship between intercostal and the medial brachial cutaneous nerve is that they are inversely proportional. That means if intercostal brachial nerve is supplying a considerable degree, then the other MBCN would be supplying a lesser portion. And we cannot hope to forget the cervical plexus through its medial, intermediate, and lateral cutaneous branches of the supraclavicular nerves supply the infraclavicular region. And the most important thing is breast does have a sympathetic supply from the middle and the cervical ganglion and the stellate ganglion. We must be wondering that how uh, endocrine organ would be having a sympathetic supply. It's through the middle and the stellate ganglion and through the branches which actually supply the muscles of the region. That means the lateral pectoral, medial pectoral, as well as long thoracic and thoracodorsal nerves, which are responsible for muscular innervation, do carry these fibers. The point which enters our mind is that medial pectoral and lateral pectoral nerves are motor nerves. If they are actually motor nerves, how are they responsible for nociception? But if you go through these articles, you would realize that they do have nociceptive and proprioceptive fibers, thereby meaning when the surgeon uses cautery on the surface of these muscles on which the breast tissue is situated, it can result postoperatively in some disruption, stretching, or spasm of these muscles and can be associated with myofascial pain. That is why we need to take care of these nerves in relation to breast surgery also. Now coming on, now coming on to the anteromedial part. When we approach close to the sternum from the mid-sternal line till mid-clavicular line, the innervation is by the terminal portion, that is the anterior cutaneous branches of the intercostal nerve, and these nerves come and lie on the surface of the pec major. Now, up till now, what we have studied is the innervation of the chest wall. Next important aspect is to discuss about the various regional anesthesia analgesia options which are available in the armamentarium of anesthesiologists for chest wall surgery. So we'll start from the neuraxial and the paraneuraxial techniques, enumerating the classical thoracic epidural, the thoracic paravertebral block. Then we come to a region which is very simple and similar to them is the paravertebral by proxy. As the name suggests, we are not reaching the paravertebral space directly, but we are depositing the drug at some distance, as we'll be studying in our subsequent slides. And there are host of blocks, the erector spinae, retrolamellar, intertransverse process block, which is the umbrella term, which is for midpoint of transverse process to pleura, the still block, that is subtransverse interligamentary plane block, and the costotransverse foramen block. And then as we move more laterally, we would realize that rhomboid intercostal plane block and rhomboid intercostal subserratus plane block can be used to anesthetize the lateral cutaneous branches. And the classical ones which are being used for breast surgery is the PECs and the SAP, which every one of you must be aware. And the facial plane blocks for the midline surgery are the parasternal blocks, particularly the pecto-intercostal facial plane block and the transverse thoracic muscle plane block. In subsequent slides, I'll be discussing majority of these blocks which we can use in our day-to-day practice. Now coming on to the gold standard for ipsilateral hemithorax anesthesia, that is the thoracic paravertical block, is essentially a regional anesthesia technique where the local anesthetic is injected into the paravertebral space adjacent to the vertebra. It produces the ipsilateral somatosensory, motor, as well as sympathetic block. So let's understand the anatomy of the thoracic paravertebral space. This is a space situated adjacent to the vertebral bodies. On the medial side, as you can look into this cross section, is the vertebral body and the intervertebral foramen.